again, we are talking about here, we were left personal medical information. Remember, we are talking about the types of formats that we use to enter patients' information inside the medical record. So the chart of the history of the patient. So remember, most of the formats that we have to collect the patient's information are templates. So already they are customized for the type of office that we have or the type of office the patient is visiting. So that's basically what it is. So once again, one of the things that you need to understand is when a patient is having troubles filling out these forms, you should assess them. So you're probably going to have a question in your exam when they say, okay, so you are the medical assistant, you see or you notice that the patient is having difficulties trying to complete these forms. What would you do? So they give you 4 options there. Remember, this is a multiple choice, single answer. There is no A and B is correct, B and C is correct, all of the above, none of the above, none of those. It's going to be one single answer within the exam. So it's not the way that I give you exams. Some of them I give you A and B, so you can see the different options. So just in case you see more than one option over there, you know that that is the one. So I don't want to give you only one option, and it turns out that when you're taking the test, you're going to see something else. So I give you options, all of the above, because it might be one of those. And if I mention only one, you're not going to be able to, get the right one when you are selecting or choosing that answer within your test. So you're going to answer that you are going to assist the patient. So you're going to read to them, you're going to interpret to them what exactly these questions means so the patient can enter the answer. Okay, do you have any medical conditions? For instance, do you suffer of diabetes? No. Just check right there where it says no, or just leave it blank. So that's basically what it is. Mark the little boxes. Just put an X whenever you see something that you have. If it is a procedure that was done to you before, you're going to mark it. If it is a condition that you have before or you still have, you mark that. That's it. Left off whatever doesn't pertain to you. But we have to be there to assist the patient. Remember, sometimes we have language problems or barriers. Sometimes it's just that we don't understand these terms. We don't know about these medical conditions. And you might left off something that is really, really important for the medical to know. It's not that the patient is trying to omit some information. It's just that the patient doesn't understand these words, these terms. So we are going to assist them. Once again, you see the patient struggling, you give them a form, it's taking too long, and they go around and around, and they look around, and they don't know what to do. Jump in, just ask them, not a problem. If you are professional and you are with good intention, they're gonna notice it. Oh, excuse me, Mrs. Brown. Can I assist you with something? Can I help you complete the form? So that's how you have to do it. So don't tell the patient, oh, well, you're taking too much time. What is the problem? Are you having issues right there filling that form? Come, give me that paper over here. I'm going to do it for you. No, that's not the way to help to assist the patient. You're going to make them feel uncomfortable. You're going to embarrass them. So once again, you have to be empathetic. Help them with good faith. I want to help you, so I'm going to do it in good terms. Remember, it is our obligation to assist the patients because that's going to accelerate, speed up the time because you're taking too long, I'm going to help you out. I just want to make sure that we do everything correctly. Remember, the doctor needs to know every single detail about your medical history, your family history, your social history, everything. The most, accurate information that we receive, the better for us as medical practitioners and for the patient's outcome as well. So that's basically what it is with this personal medical information. Remember, we need to know medical conditions, procedures, medications, only related to the patient. Now we're going to move to the patient's family history. Now, once again, this is as important as the patient's personal information. Remember, if it runs in the family, if one of the members of the family has to be someone related, has to be someone related by blood. So in-laws do not count. So be careful with that. So in-laws did not count. Oh, this is your mother-in-law, your father-in-law. This is someone else's son and daughter. No, they can call you uncle, they can call you aunt, they can call you this or that. But if they are not related by blood, they do not count for history. So who counts for history? Your parents, your grandparents, your great-great-grandparents, all of them. This is how it works. Your cousins, your brothers, your siblings in general. Once again, the in-laws do not count. So that's basically what it is. The family of your parents from the family side, well, if they are the uncles, the real uncles from your father's side, of course they count because they might share the same genes, the same DNA. So again, has to be family related. So we're going to see what conditions the family had or had in the past. So that's important. Remember, every single piece of information is going to help the medical doctor to expedite diagnosis. We're not going to spend too much time trying to figure it out. What's the reason? What's the problem with the patient? It sounds like this. It might not be because of the age related. Remember, we have a problem with conditions that are hereditary or are passed on from family to their offsprings. So we have a lot of issues with that because whatever you got from your parents, if we don't know that your parents had it, we're going to have problems. So we're going to do too much investigation, too many blood tests, imaging reports, examinations, probably referrals, maybe with no need, or we're going to omit to do all this. Remember that when a family member suffers a condition, there are 10 to 15% chances that one of the family members will develop that condition. So one of them might have the condition. So chances are, and we don't know if that's the person that we are dealing with on that particular day in our office. So we need to know, particularly when it comes to these chronic diseases, they are very detrimental for the patient, like diabetes, high blood pressure, heart conditions, or any type of cancers. So when we have the patients, if we know that the patient has a family history of someone having cancer, well, we're going to do exams, we're going to order procedures before they actually we have to do it because there are certain age related procedures. See, if a patient suffers doesn't have problems with cancer, we don't do colonoscopy until the patient reaches 50 years old. Now, the patient has family history of colon, any parts of the colon, the large intestine cancer. Well, if the patient relays that to us, we have that information, then what is it that we're going to do? We're not going to wait until the patient reaches 50 years old to do colonoscopy. We're going to do it at 30, 35. And from then, very often, not every 4 or 5 years. We're going to do it every year because this person has a family history of someone who had or is currently having the cancer. So that's what we do. Female says, "Oh, my mom suffer of breast cancer," or "My mother passed away from cervical cancer." Well, we're gonna order whether it's a mammogram or a pap smear. We're gonna keep our eyes on this person. Why? Because he has a family history. The same with hypertension. Depends of the gender, depends of the ethnicity or race. We are going to follow certain things that are more common in some genders and some ethnicities. So we're gonna follow that. But if we do not have knowledge of that, then we probably gonna miss something. So remember, everything that we do is to cause no harm when we're talking about the patients. Beneficiency, all the time. We're going to try to benefit the patient. So that's what the patient expects from us, that we do wherever it is in our power to help them with the medical conditions. But then we require from our patients to give us as much information as possible. If they don't know, it's a different issue, but we should not omit or we should not just disregard whatever the patient is telling us, because that's very important. So remember, physical conditions of member of the patient's family. Any medical condition has illness or diseases, anything I mentioned already, any causes of family members' death, I mentioned it already. Somebody died from a heart condition, somebody died from this particular type of cancer, or anything else, or diabetes, which are these very common conditions. So when we know that, we're going to make sure that we are going to be on top of our patients' care, because it might happen to our patient as well. So that's kind of, being ready, being preventive, because remember, we always try to prevent. It's better to prevent than to cure. So we're not going to wait too long to find out that the patient already have something that it has advanced too much. So it might not be good time now to save the patient. So that's basically what we do, family history. So here it is, another form, another template. The good thing about these templates is that the information is written there, most of the information. So we just go over and we are going to help the patient. Remember, we're going to assist them. We're going to read it for them. Has your husband had, or your wife had, or had in the past this condition, this condition, this condition, any type of conditions? Oh, well, I know that they have this surgical procedure. Oh, well, probably there was something there. They don't recall what they have, but something might be there. If there is something that we do not know or it's not written there, then we're going to add it right here. So it's going to be in space for us to add something that is not written, that is not one of the questions, that we can just check them. So that's basically what it is. Very simple for us because we understand a little more than the patients. So we have to assist the patients, give them the forms. Don't let them struggle with these forms. Offer your assistance. Oh, here is this. Can you fill in this particular form? If you need any assistance, please let me know. Okay, I'm gonna be around. Let me know. It's by the time that you give the form. You don't have to wait until the patient is struggling trying to complete this form. It's at the beginning. So the patient feels confident that if they need some help, they're going to come to you. Otherwise, they're going to feel kind of embarrassed. Or some of the patients that just don't like to ask. But if you offer your assistance, they're going to come to you because they're going to feel that you're going to be helping them. Patient's information form. Now, this is the patient's personal information. This is what is called demographics, remember. All these forms are going to be attached. It's going to be in each one of the sections of inside the medical records. So here is when we have all, once again, the patient's personal information. And when we talk about patient information, we're talking about not just the name, the last name, the day of birth, the social security number, the telephone number, the address, and every email. Well, we also have family information as well. If it is married, if it is whatever marital status they have. The family, the insurance. So we're going to have lots of information from the patient, as much information as we can collect. So it's important. So we just read the form. All these forms are, varies from practice to practice, but they try to collect most of the person's or patient's personal information. So that's basically what it is. We're not going to go over every single detail. Okay, so patient social history. Once again, important as anything else that we're collecting from the patient. Why? Because this is going to help us out also to determine if whatever you're having right now has to do with your social history. So what is the social history? The patient's lifestyle. Patients do exercise, the patient drinks alcohol, uses drugs, or just smoke regular cigarettes. Does the patient works? What does the patient do? All this has a lot to do with what the patient probably is presenting to our office for care. If you work in construction, you have to lift, heavy stuff, or moving up or something like that, the ladder, well, you might have developed something that is related to the muscles, to the bones, trauma, who knows? So we need to know. The things that you eat, all that is important, whether you're married or single, whether you have a job or not, whether you have some psychological problems or not. So again, this is very, very important. Remember, sometimes the patient might develop something that is not related to the body itself, to the organs. It's not that the organs are sick, ill, disease. It is psychological. It is emotional. So we need to know what's really going on with the patient. So these help us out. See, if you don't have a job and you have responsibilities, you have to pay bills. Who doesn't have to pay bills? Well, probably the little kids, or the ones that still lives with mom and pop. But if we live anywhere that we are, and as an adult, we usually have bills to pay. And if you lose your job, now you're gonna have emotional problems. So you're gonna become sick. You're gonna be stressed out. So again, you're gonna be very sad. You're gonna be depressed. You probably don't want to do anything. Probably you don't want to socialize. Probably you don't have food to eat. So you're going to get sick. Probably you're going to have the intent to commit suicide. So all this is important. You're a single parent. That's also something that is important. That's what we ask about the marital status. Whether you are married, single, divorced, it doesn't matter. Just because you're married does not imply that everything is going right. Maybe the relation is not going good, and that might be some of the problems that the patient is having problems with the relationship. Remember, emotional, psychological. Oh, you show up to the office and you're coughing, and it turns out that there is no virus, there is no bacterial infection. It's your tobacco abuse. You're using you're smoking cigarettes and you're smoking a lot. So right there, that's an indication. Probably when you went to the doctor, one of the questions that they ask when we have physical exam, complete physical exam, is then they ask you, do you smoke? And if you say yes, that's not enough. Why? What do you smoke? And how often do you smoke? And how much do you smoke? If I smoke 1 cigarette per week, well, that's not going to kill me immediately. But if I smoke a cigarette, 2, 3, 4, 5, a package per day, that had consequences. Do you drink? Oh, no. Well, listen, the only one who doesn't drink is me, because I don't drink. It doesn't matter what celebration. I don't. Maybe once in a blue moon, I have a little kind of, a little wine, just a little bit, be celebrating something. My family's there and they want to, uh, share with me. So I just pretend that I drink. I do not drink. But 99% of the population drink. Now, remember, do you drink how often? Remember, everything is how often. This is not just something that, do you drink? Yes. Oh, patient drinks. No, what is it that you drink? You might drink just a couple of beers. Is that going to kill you? Is that going to make you sick? No. Oh, no, I drink vodka, whiskey, oh, rum. I don't know, heavy stuff, heavy liquor. How often? Every single weekend. So that's the point, to get all the information, the most accurate information. Drugs, you have to ask, because that might be the reason why you are getting sick or injured. So again, these topics are very sensitive. So we have to ask. During the social part, don't get upset, don't get offended when your doctor asks you if you are, have relations with men, if you're a woman, and with women. A male, they ask us, do you have, a heterosexual relation? Or are you bisexual? Or are you homosexual? That is not trying to embarrass you. We need to know, because the infection that you have, maybe you acquired through this type of relations. So we have to answer the questions to the best of our knowledge and our interest. So I'm telling you many things because I want you to understand that some of the questions, even though if they are very sensitive in nature, it has purpose in medicine. So don't take it personal. Don't take it as being biased or being discriminated. No, it doesn't have anything to do with that. So yeah, it's a little uncomfortable, somebody, because it's very sensitive. It's a little uncomfortable. Somebody asks you, Well, if it asks you, do you drink? No, no, that's not a problem. Do you smoke? Oh, not a problem. But now when it comes to drugs or, sexual orientation, things gets a little more tense. It's very sensitive. So we need to know when to ask these questions. These questions are never asked at the beginning of the interview when we do in the physical. We do it at the end of the interview when we already entered into this kind of relation, talking and answering questions. Then we hit you with, oh, do you smoke? How many cigarettes per day? Oh, no, I smoke one of the blue, but I need to know. Alcohol, the same. Drugs, the same. What drug do you use? How often do you use it? Remember, this might be the reason why you are sick or that you have this particular condition. So we need to figure it out. So employment, what is it that you do? That might be what's getting you sick. Are patients that they work in a coal mine. They were exposed to all these chemicals, all these fumes. So they develop lung cancer or chronic bronchitis or COPD. But if I don't ask, might think that that's not important. But that's how we lead ourselves, our conversation. Remember, medical doctors are like detectives. Go over and go and ask questions to the patient to lead us towards whatever complaint you have, if it is related. If somebody's coughing, well, oh, probably it's the flu, but no, that's not what we assume. It may not. It might be something, a lifestyle. So again, we follow everything. We ask almost anything to make sure that we have as much information as possible from our patient's point of view. And you have to tell us the truth, because if you don't tell us the truth, again, we might, use unnecessary testing, put you through all this testing when actually it's not needed. And some of the insurance don't even pay for some testing. They don't pay for more of whatever they have been assigned to you. So again, your condition might get complicated because we don't have enough information. Remember, some of the patients just omit some information because they feel uncomfortable, they feel embarrassed to tell. But then we got to go immediately and tell the patient, remember, this information is going to be exclusively for us, the medical people. Nobody else is going to know about this information. This information is confidential. The only way that this information is going to leave this office is if you tell them, not us. We're not going to tell anyone. But at the same time, we're going to use this for your benefit. This is how we are going to rule in or out any probably a conflicting diagnosis that we may have. We're not sure what is this, but knowing that you have this is going to help us out to determine faster the condition that you may have. So again, this is very important. Can you imagine someone not having a place to live, is homeless, is exposed to a lot of things? Think about that. We know already being homeless means not only that you don't have a roof with spend the night, but you don't take showers, hygiene problems can cause you to become sick. So again, you're not eating properly. So you are exposed to all these environmental issues. So we need to know And based on that, once again, we're going to rule in or out whatever is going on with the patient. Let's move now. Any questions? Let's move now to, oh, hold on a minute, please. Have someone messaging me. Okay, answered. Thank you. Okay, so the patient's chief complaint. Remember, 100% this is a question for your exam. Always. And I just, I place it right there. It says, I type it right there, CC. This is a brief or an abbreviation for chief complaint. Remember, they're gonna ask you, what is the chief complaint? The chief complaint is the reason why the patient is coming to the office. The patient is looking for care. What is it that is going on with the patient? So that is the chief complaint. So it's very important for us to understand what it is. Remember that I ask you in the questions in the exam because I want you to have it. So when you see this in your national certification, you're going to say, oh, I know this. You can imagine how good you feel when you encounter those questions. It says, oh my God, I know the answer versus I don't know what it is. So I try to cover as much as possible so you can feel at ease, understanding, learning, but also not only what you're going to be utilizing on your workplace, because you're going to encounter a lot of stuff, even though if you're not going to respond to the answers, but you know already what is it that we went through. You know what you have to do because we have covered it already. That can be learned, that can be reviewed, that can be retrieved. But then when it comes to the exam, oh no, this is just one time, or you make it or you break it. So again, so you're gonna feel very comfortable when you see those questions and you're gonna say, I got it. So every time the patient comes to your office and they complain about something, remember symptoms, I have this, my belly hurts, I have a back pain, I have a headache, I have a rash, I have fever, I'm been coughing, I have a cough. So all those things is swollen. Anything that the patient tell you. The patient not always come to our office just because he needs healthcare at that particular moment. They don't come here because they have problem. They might need a form to be filled out for employment. They might come for vaccines. That's a chief complaint. I'm here for my vaccine. I'm here because I need a note. I was here a week ago, and now my boss is asking me, well, what you were late that day, or what didn't you show up that day? I said, oh, I was at doctor's office. Bring me a note. So you go there. Of course, for that, we don't register you. There are certain things, but if you go for blood results, you're not there because you have a problem, but you're not going to go there for that reason. You need the blood results. So not necessarily you go there because you have a problem at that time. You can go for a prescription refill. That's the chief complaint. It's what the patient is telling you. Remember, it's subjective. So the reasons for the patient seeking for medical care, that is what's called chief complaint. Remember, you can have the whole word spelled out like chief complaint, just like it's here, or you can have just CC. So get familiar with that. because not always you're gonna have the whole word spread, spelled out. You might have the answer as CC. You might have the answer as a chief complaint. Remember that, well, not remember, I'm telling you, whenever you're taking a test, there are different versions of the test. You might have version A, though your colleague or your classmate might have B, the other one might have C, D, or E. So the questions are kind of randomly selected. Some of you might have a question when you have chief complaint that is spelled out. The other one might have the acronym CC or abbreviation. They use these terms interchangeably, even though if it is not correct, but sometimes it says, oh, abbreviation. CC is not an abbreviation. CC is a acronym. HIPAA is not an abbreviation, it's an acronym. Abbreviations is when we use the first part of a word. Instead of, spelling the whole word, typing it the whole word, we just say the first part. Let's say, for instance, info. Info means information. So I don't want to type information, it's too long, but if I said info, you can understand. So when we use the first one or two letters of a word, that's going to call an abbreviation. An acronym is when we use the first letter of each word. That's a different issue. So again, very important. The patient tells us, oh, I have a headache, I have pain, I have this. Well, we have to go through serious questions. Okay, so you say they have a headache. Good. Just write it down and then, okay, you can have a seat. The doctor is going to see you. Depends on the practice that you are. Depends on what is the policies for the medical assistant, what other information you should be collecting. Then you will go about that. Other than that, remember, it's just simple. What is the reason? Hi, Mr. and Mrs. Brown. What is the reason for your visit today? How can I assist you today? Oh, no, I have a back pain. Okay, anything else? No, that's about it. Well, back pain because the doctor told you not to ask anything else, just to write down the chief complaint. But in reality, we should take a little more information than that because it might be more serious than it may look. So some of the things that we're going to ask are the nature and duration of whatever is going on. If you have cough, if you have pain, swelling, fever, diarrhea, whatever the case may be, you are going to ask, by the way, for how long it's been going on? For how long do you have this pain? For how long do you have the fever, the cough? It's like asking a little more. Why? Because it might be an emergency. It might be something serious, and if we disregard it, patient can collapse right there in the waiting area. Oh, but you didn't ask. Oh, look at the patient collapse. Oh, they didn't say anything. They just say that they have a pain, they have fever, they were just coughing. Well, they don't have to say anything. It's us that we have to elicit those questions or those answers. So we always ask the nature of something. If it is pain, okay, the first thing that has to come to our mind is, oh, do you have a trauma? Do you hit your head, your back, your leg, wherever you have the pain? Do you have any type of trauma? No, no trauma. Okay. Any infection? Oh, no, not that I know of. So we are kind of, eliminated certain things. We are sorting out just in case it is an emergency. Simple. Or we might have to place this person first. Can you imagine a patient coughing and with a fever? You might have something that is going to be spread in the waiting area, including you who are taking care of the patient. where we might need to separate this patient, put it in a room by themselves to isolate them while you are, while the patient is seeing them. So that's basically what it is. So we have to do a lot of stuff. Time with the patient first notice the symptoms. That's another question that you can make. You ask for what's the nature, what is it? What is it that you have? For how long it's been going on? When do you notice that? Oh, I have this fever like this morning. I have this fever for a couple of days and it doesn't go away, even though if I'm taking medications, because we are going to ask that. So again, we have to be a little more, interactive. We need to know exactly what's going on with the patient. Now, again, if somebody says that they've been with fever for more than 1 day and they've been taking some medications and seems not to relieve the problem, that can be something serious right there is telling you versus someone that has fever right today. And they haven't taken anything. They just came to the doctor. But it's different. Something that has been going on because it's serious. Having fever for too long, it's not good. So we create a little image of what might be happening for the patient. Patient's opinion about possible causes of difficulties. Now, remember, I mentioned it already. What happened? Did you fall? Somebody hit you? If you're having pain? If you are coughing, well, were you exposed to someone else? Someone else at home have the condition? So those are the things that we need to ask, because we need to know whether these might be contagious, whether someone else is having the problem. Again, anything that you have taken, remember, oh, I took Tylenol for the fever, but it didn't relieve the fever. Oh, it seems like I feel a little better, but then the temperature goes up again. If it is for the pain, the same. Oh, I took some pain medication, some over-the-counter medications. Sometimes it's a good thing to know what exactly they took. If they know what was the milligrams. See, I have someone that works for me, not here, but whenever they get a little sick or, they work in my farm. So whenever they call me, says, oh, I have this. And I said, oh, did you take anything? Oh, yeah, I went to the pharmacy and I got something. What was it? Just tell me the name, because they always use this common medication, right? Like Tylenol, acetaminophen, oh, that's what it's called, or ibuprofen, or Advil. So I said, okay, how many milligrams are each one of those tablets? Oh, I don't know. Well, that's important, because medications dosage are based on the patient's weight and age. So if you're taking 200 milligrams and you are 130 pounds, 40 pounds, 150 pounds, that's not going to do anything. You at least should take, if you're 120 pounds, at least you should take 500 milligrams every 4 to 6 hours. Otherwise, it's not going to work. And you're telling me that you're taking 200 milligrams and you took it this morning and you haven't taken it and it's 4 p.m. Well, I wonder why you're not getting better. But the patients do not know this. So sometimes it's just, asking a little more. Oh, the fever didn't go down. Just to say it in this terms. Well, what did you take? Oh, I took Tylenol. How many milligrams? I don't know. Well, we have 200 milligrams, 400 milligrams, 500 milligrams. If you take 2 pills, then you double that. So again, we need to be a little more proactive asking questions. See, we're going to ask the patient whether they have this in the past. Because if they have this in the past, it might be that the patient has something chronic. So the patient has been exposed to this. So that's telling me, well, this patient probably is not going to die. They have this before and now they're here. Remember, it's not that you're going to disregard what the patient has, but it's not a priority. If someone comes with an issue that put the patient more at risk, probably it's going to be passed first. So it's going to be seen by the doctor first. Now, it's not that we're going to use that all the time because, if you have an appointment at this time, first come, first serve, if you just walk in, applies. Sometimes we need to know a little more because the patient might actually need to be seen faster before the condition actually worsens. So that's basically what it is. See, past medical treatments for the same condition. What did you take for that condition when you have? Oh, the same thing, the ones that I'm taking it right now. Did it help you? Did it relieve the pain? Well, yeah, but it's temporary. Well, we have to know something that's just for your knowledge. Don't panic when the patient says, oh, I took something, but well, it helped me for a little bit, but then, well, that's what medications do. That's for temporary relief. These pain medications, most of the medications that we give to the patient is not to actually get rid of the problem, is to eliminate, to relieve these symptoms. Even though if the condition is still there, we are relieving the symptoms. Because think about this. What is the major reason that the patient come to our office? Because they are feeling symptoms. If I don't feel like I have fever, that I have a swollen leg, arm, I don't have a headache, I don't have a cough, I will not go to the doctor. So most of the time, the patient goes to the doctor because he's feeling something. It's not feeling comfortable. It's bothering this person. It's not allowing this person to do their daily activities in a normal fashion. So they're going to come to us. So again, if you don't have symptoms, these patients, they're not going to go to the doctor. Who's going to go to the doctor just because you're going to go sit in the waiting area? Well, unless you feel lonely, unless you're homeless, then I will see you there. I mean, this is true because in the emergency, we have all the homeless in the waiting area, particularly in wintertime. They're just looking for shelter. So that's a different issue. This is the medical doctor's office where you just come and go. Remember, this is an outpatient setting, ambulatory. So that's how it goes. So whenever the patient has all these symptoms, this is what exactly we as a medical providers, we do. We're going to see, we're going to get to the bottom of the condition, asking all these type of questions. So if you are allowed to do this, because some medical doctors ask the medical assistants to do this preliminary assessment from the patient, this preliminary questionnaire. And it is okay if you've been asked to do it, but if you don't, just don't do it. Don't get involved. But eventually, this is good for you. So when you go to the doctor, you are prepared to mention the things because you already know what they're going to ask you. So you're going to kind of prepare. So if you don't know your medications dosage or the medications that you're taking, hey, you don't need to memorize these names. I don't even know them myself. But you have to, bring the prescription, bring bottles. I said, oh, listen, I don't know the name of the medications, but here are the bottles. Oh, excellent. That's what we want. We need to know exactly what you're taking. And when we see the medications, we know what you're taking it for. And if we do not the names of those medications, not a problem. We have the database in the computer and we go there and we find out. And we know what's the medication for. So as soon as I see the medication and I know what is the medication, I know what you're taking it for. just the fact that you're telling me about the medications. So again, it is very important to have the information. And this is something that you got to do, because when you set up an appointment for a patient, for a new patient is going to come to the office because they talk to you over the phone, or they completed the application online through the patient's portal. Well, guess what? You have to approve that appointment, right? Because that's what we cover when, for those who took, scheduling with me. See, all this comes back to haunt you because everything is needed. So you're gonna ask the patient, say, hi, are you taking any medications, whether it's over the phone, whether it is online? So you can ask them, you're gonna, send them a message. Please bring the medication that you're taking, okay? The names of the medication, or bring the bottles. Because it's very hard. To be honest with you, nobody can remember all those medications unless it's just silent. Because remember, patients do not tell you what is the name of the medication. They tell you what is the condition for which they are taking it. Oh, I'm taking these for blood pressure, something like that. Oh, yeah, of course. They're not going to say hypertension, but there are many medications for blood pressure. There are many medications for diabetes. There are many medications to relieve pain. Okay? So it's a lot of stuff. And the patient is not going to memorize all of this. So we're going to ask them, oh, just bring the names of the medications and the dosage. And if you have the bottles, even better. Remember when the pharmacy delivers the medications to you, or when you're going to pick them up, it's the same. They deliver it to you right there in the office, face to face, or they bring it to your home. The medications come with, an insert, like a little pamphlet that has all the information from the medication. Well, bring those. That as soon as I see them, I know what is it that you're taking. It might be one of these medications that you're taking that is causing you all these symptoms. That's the reason that you're here. So you see how easy it is when we have most of the information. And who is going to give that information? The patient. But who is going to trigger that information? Who's going to elicit that information? Us, the providers. So that's what's important. So it's not just about, oh, the chief complaint. Yeah. The patient has this. I have a headache. Now I have to investigate what type of headache. Again, there's a lot of stuff. But we need to make sure that we get most of the answers from our patients, because that's the only way that we are going to come out with an assessment, remember, which is the diagnosis and the plan, how we're going to treat the patient. Any questions about chief complaint? Okay. So let's talk about the pain scale. For those who did with me some vital signs, most of you still pending vital signs. So it is include your blood pressure, pulse, your heart rate, respiration rate, oxygen levels, and pain. So when would you actually ask the patient for pain? Well, when the patient complains about pain. See, these are things that are exclusively depending on the chief complaint. If the patient is complaining about fever, then you're going to check temperature. You're not going to check temperature in everyone if that's not my concern right now. Patient is talking about, they have the chest, the heart seems like it's going to, come out from your chest. Well, then I'm going to do blood pressure. I'm going to do pulse. So depends on what the patient is complaining about, then is when we do some of the vital signs or the weight management. or the measurements, so to speak. Oh, when do I check height? When do I check weight? All depends. What's the reason that the patient is there? That's the most important thing. That's what always we follow the chief complaint. Because from the chief complaint, we know exactly, more likely, what's the doctor is gonna order us to do. So don't ignore the chief complaint. That is a key factor for you to know and expect something that the doctor is gonna call you and ask you to do from the patient. So whenever the patient comes with pain, says, oh, you know what is the reason that you're here, Mr. or Mrs. Brown? I have a back pain. Okay, so this is how you're gonna ask. Okay, Mr. or Mrs. Brown, using a scale 1 to 10, being 1 a very mild pain and 10 a very severe pain, how you rate your pain? So then, well, sometimes patients are very honest. Remember, honesty is very important. But some patients do not understand that. Not because they wanted to do it on purpose, but they have a means. So the patient is going to say, oh, like 5. Don't disregard it just because they say 5. Oh, that's not important. People do not have or feel or complain about pain the same. We have different levels of bearing the pain. So that's basically what it is. So you just write it down. Pain scale 5 out of 10. That's it. So that's how you are going to record this. And remember, if the patient says, oh, 100, remember the patient sometimes they are not honest, because if they say 5 or 6, they think that the doctor is not going to care about it. Oh, that's not actually pain. No, we're just being honest. Because if the pain is not as bad as you are telling me, then you're lying to yourself. Because the reason that you're telling me that is probably because you think that if I tell you that it is 10 or 100, the doctor is going to be seeing me immediately. That is not the case. We're not going to tell the patients, just going to ask simple. Just like that. So tell them that, and you're just going to write down 8 out of 10. That's it. So usually you don't have to write all that down. If the patient sets A on a scale to 10, so you just put like this. This is 8 out of 10. 5 out of 10. That's what it means. 2 out of 10. Okay, not a problem. So the doctor is going to read it, and they know exactly, because it says pain scale, because it goes from 1 to 10. Remember this for your exam, because they're going to ask you, okay, the pain scale, how is calculated the pain scale? Oh, from 1 to 10. That's the scale that we use. So it must sound simple, but if you don't know it, then you're going to have a little issue right there answering these questions that are straightforward questions. So they can set the most excruciating pain, the worst pain that you have, or a very, very, bad pain. So it's the same, having a mild pain and then having a serious, excruciating, the worst pain that you ever had, a really, really bad pain. All those terms are the same. So you use the words that you feel comfortable with. That's simple. Do not try to use the words that I use. What you try to do is that your patient is going to understand what you're asking them to respond. And you're not going to put words in their mouth. Oh, well, I don't know, 1 to 10, I don't know, maybe 5, 6, maybe 2, maybe 10. We do not lead our patients to say anything, just from 1 to 10, being 1 very mild pain and 10 being a really bad pain, because sometimes the patient understands that, versus excruciated, the worst pain you ever had. So think about it. It's not about how fancy the words are, it's how simple the words are and that the patient understands. And they can give you an honest or fair questions. So that's basically, so that's pain scale. Remember, we do certain vital signs depending on what the patients ask, what the patient chief complaint is. So that's how we are going to understand this. So we're going to be prepared. Objective information. So we kind of cover all the subjective. Remember, subjective is most of the information that we collect from our patient. So that's basically what it is. Most of the information that we collect from them, remember, if it comes from the patient's mouth, that's going to be subjective. And the subjective part are called symptoms. Most of the symptoms, how you feel, back pain, fever, cough, all of those are symptoms. Once again, if the patient said are symptoms. If they are symptoms, this is known as subjective information. The patient is assuming that they have that, that's how they perceive that. But then it might not be exactly what they feeling. Or might be that they feeling that, but not related to what they think they have. So we got to make the work to figure out what is it that you have. Because if the patient knows the diagnosis, then they just go to the pharmacy and buy medication, right? Well, no, because the medications, some of the medications are not going to be given to the patients. Some of them needs to be prescribed. Not every single medication is over-the-counter medication. So objective, these are the findings. And usually these are the findings done by the medical doctor, the examinations, the findings, when ordered blood tests, because we're going to see what is within these blood tests. So when they see the results, we put it together, and then it's like a puzzle. We ask all these questions to you, then we order certain exams, we put all the information that you gave us, plus the results that we have, and we put it together. Now we come out with a differential diagnosis. Differential diagnosis is a bunch of things that we might think you have. But then when we have these test results and things like that, well, we're going to get to the bottom of that. So now we're going to narrow to one condition that it is what you have. So that would be the principal diagnosis. So that's how it works. So all this everything that is done in the medical that is considered objective is done by the medical provider. And when I'm talking about the medical provider, it might be you. Yes, the medical doctor is the one that diagnoses, but you help them by doing the EKG, doing the bloods, the lab results, all those things are part of the objective. So it's not what the patient says, it's where the physician, the medical provider, fine. Those are objectives. So think about that. Because remember, the questions about objective is going to be, they're going to throw there some samples, some statements. So the doctor examined the patient and found out that the patient has a tumor. What is that? Well, that's objective. Now, the tumor is a cancerous tumor level, this or that. Oh, now it's an assessment because I'm giving a diagnosis. Just a tumor itself doesn't tell me anything. The doctor orders some blood work and then have the results of this one. That is called objective. Remember, assessment is just the diagnosis. So everything that the doctor do in the office, including you, when the patient, let's put it this way, all the workout that the patient receives when it is in the office to figure it out what is the problem with the patient or the diagnosis is called objective. That is it. You do vital signs, that's objective. You draw blood, that is objective. You do an EKG, that is objective. The doctor examines the patient, uses the stethoscope, uses any instrument to verify something that they suspect the patient may have. Objective. So I want you to understand this because I don't want you to get these questions wrong in your exam. They are very, very easy to be misled. So not good. Because we think that, oh, objective, how do I know this is objective? Oh, this is assessment. No, assessment is diagnosis. It's just that in order for them to use the soap, they use an A instead of using T, because it doesn't, you cannot pronounce salt. It is difficult. So in order to come out with this SOAP, that sounds better because it's a soap note. But if I have a big T right there instead of the A, it's not going to be easy to be pronounced. So that is the reason why they put something, an acronym, that it can be pronounced. That can be easy, pronounced. So that's basically how it works. So every workout that we do for the patient before we get the diagnosis is called an objective. The other one is just the diagnosis. Your blood sugar is high. Oh, diabetes. We found out that you have a viral infection. Oh, that's the diagnosis. Bacterial infection. That is the diagnosis. And what am I going to do? I'm going to treat you for the viral infection. I'm going to treat you for the bacterial infection. I'm going to treat you for the fracture. I'm going to treat you for this, all because I already know what you have. Now we're going to treat. Remember, if I order a surgical procedure to correct a problem, that is the plan. That is the treatment. So doing a procedure to correct the blood that we collect, that is a procedure, but it's not a plan. That's an objective. Drawing your blood is not gonna make you feel better. But if I do a surgical procedure to remove the tumor, then it's gonna be a procedure which is a plan or a treatment. So take in consideration all the things that I'm telling you. So when you see these questions on your exam, you're not going to be like, oh, I don't know what it is because I'm kind of all confused with all these. No, should be thinking about just what I said. So you know what is the chief complaint? Definitely. It's what the patient says. It's the reason what the patient is looking for care, comes to the office for something. Everything that the patient says is objective symptoms. So it's objective. Everything that the doctor do to determine what the patient has is objective. Remember, subjective, patient, objective, and everything else is done by the doctor. The only subjective is what the patient says, is the chief complaint, are the symptoms that the patient complains about. The doctor do not tell the patient, these are the symptoms. No, it's the patient that said what they feel. According to your symptoms, according to your, whatever you told me, this is what we're going to do. Objective. So if the blood work is not going to solve the problem, so it's an objective. If the procedure is going to solve the problem, now it is a plan, it is a treatment. So that's basically what it is. So keep in mind that when you are reading this acronym, what stands for each letter of the acronym, the SOAP. No. Any questions? Remember, signs is something that you can see, something that you can touch, something that you can evaluate. Subjective, you cannot see it. I'm very sad. Can you see sadness? I have a back pain. Can you see pain? Can you touch pain? No. I have this, I have that, I feel dizzy. Can you see dizziness? I feel tired. Have you seen tired? The word itself? No, we don't. So those are subjective. So again, but if I see it, I can touch it, I have a rash. Oh, I touch it, I see it, I measure it, and now I identify what type of rash, what was caused by. It's objective. Again, but these evaluations are done by the medical provider. That is it. Remember, the assessment is just the diagnosis. If you see the word assessment, diagnosis, patient have diabetes. What part of the soul note is diabetes? Oh, it's the diagnosis. That's how it goes. Patient complain about hypertension. The medical assistants check the patient's blood pressure. Blood pressure is what part of the soul? Objective. Just doing the procedure is not gonna fix the problem for the patient. Treatment is something that is done to fix the problem. Just putting, the words in that type of statement. So that's how it works. So I'm trying you to get this because these questions are in the exam. So what is the objective information? Physical examinations and findings. Remember everything that the doctor do, start asking you questions, start palpating this area, checking your lung sounds, checking your vision, checking your hearing, your reflexes, asking you to open your mouth, shining the light right there, looking inside the larynx, the pharynx, and see what they see. All these are evaluations, examinations, and who is doing it? The doctor. So that will be objective, because as soon as I find something, I'm going to be writing it down, writing it down, writing it down. Laboratory and radiology reports. Remember, this laboratory, like blood, urine, feces, any type of body fluid, vaginal fluid, seminal fluid, amniotic fluid, any of those are part of the laboratory. I just need to evaluate that to see if there is something in there. But it's not to treat you. It's to find out what is it, so I can then give you a diagnosis. And when I know what you have, now I know how to treat it. So that's how it works. I send you for an X-ray because you fall and we might suspect that you have a fracture. Well, when they get the results, I'm going to see a fracture and I'm going to see what bone was fractured, what type of fracture was that. Now I have to take measurements. Now fracture is the diagnosis because I found it in the X-rays. Without the X-rays, I wouldn't be able to know whether you have a fracture or not, unless the bone is sticking out from your skin. But it might be a closed fracture, so I might not be able to see it, or something else. So again, all these are, diagnosis. Well, of course, diagnosis is an objective, but we do not use it because this is just information. But we do not use diagnosis as part of the objective part within the subnote. Don't get it twisted. See, it says treatment. All that. Well, yes, there are objectives. Why? Because I already ordered the blood, already ordered the X-rays, CAT scans, MRIs, whatever body fluid. I have the results. It's just because we having something that we can prove. Blood results, it's going to tell me whether your red blood cells are high or low, or whether your sodium is high or low, with your cholesterol or your sugar, all of that. So Objective means something that you can see. It's a word, it's a general statement. I remember as part of the SOAP, that's a different issue. So don't get it twisted. Oh, diagnosis. Well, I saw there that it was subjective information. Yes, it is subjective, but in the sub-node, diagnosis is assessment. So that will be A on the SOAP. Treatment will be P from the SA the sub-node. So that's basically what it is. The progress notes. Now, remember, this is what we use within the progress notes. We use all these forms, all these SOAP, the sub-note, to write down in the progress note. The progress notes is just a form. And we're going to have there all this information. Remember that we had the progress note before. Let's see, gotta be around here. Here it is. See the sub-note. Subjective, objective, assessment, and treatment. So that's basically what it is. So this is the progress note. It can be in different shapes, of course. It might not have the images, depending on what is it that we're doing, depending on the specialty that is using it. But this is what we use to diagnose our patients. We collect this information when we use the source-oriented medical records, and that's it. We don't have to go through every single details. It's just the part that we actually interested to determine what the patient's conditions are. Oh, so that's basically what it is. So objective just means that it's something that is done by the doctor, something that you found, something that you can see, something that you can treat. I don't see diabetes. I don't see cancer, but I see the tumor. I see the results. So that is the objective part. Any questions about subjective, objective? And what is the, the acronym, each word of the sub-note, how can be interpreted when they give you samples? So that's important. Diagnosis. See, we have 3 ways or 3 levels to diagnose the patient. We have a provisional diagnosis. Now, this is good for you. Here, if you have anything about, it's going to be the second one, differential. So provisional diagnosis, nobody's going to ask you. So provisional diagnosis is the first impression that the medical doctor has after collecting the patient's information. Oh, I have a headache. Oh, well, headache. That's my diagnosis. I'm getting an idea. I have back pain. I know you have a back pain. So now let's see what causes it. Because that's the most important thing. Because that is when we want to use the differential diagnosis. Provisional is something temporary. Remember, it's something that I kind of gather immediately as soon as the patient tells me what is the chief complaint, and I start asking few questions. Now I'm kind of, narrowing down a condition that I might think you have, because that's what we do. We listen to you, we have an idea of what your first complaint was, and then from then on, we are going to be asking you questions. That's called eliciting questions from the patient, and then we're going to get that information, and that information is going to lead to another question, until we get to the final diagnosis. So from the provisional, the temporary diagnosis that we create in our minds when we're talking to the patient, that can change. That's not the one. It might be the final, but for now, it is just provisional because I'm waiting for all this information that I'm collecting from my patient, the exams, the evaluations, plus the tests if I order any tests, any laboratory testing. So when I say laboratory testing, does not include only blood, urine, and any other body fluids. No, it might include imaging reports, X-rays, CAT scans, MRIs, sonograms, anything, an EKG. So then after I ask all these questions and I have some results, some exams, some evaluations, examination from the patient, I'm examining my patient, I'm listening to the lungs, I'm listening to the bowel sounds, I'm checking the patient's hearing, the patient's vision, all those things, their reflexes. Then, I have like 3 things. Some of the conditions are kind of straightforward. So I know when I see it. If it looks like an elephant, walks like an elephant, well, it is an elephant, right? But some of the other conditions are not that simple to diagnose. So I might have a bunch of things, 1, 2, 3, 4 things that I might think you might have. Well, this is differential. When I have more than one thing that I think that's what you have. So I have to run other tests, more complex tests. I might need an X-ray, CAT scan, MRI. So with the examination, it was not enough. I need blood work. So I have 3 things, 4 things in mind because you have symptoms that are similar to these different conditions. So they share these similar conditions. See, someone come to my office and is coughing. Well, the first thing that I think is, oh, they are coughing, but it might be viral infection. It might be bacterial infection. It might be that the patient smokes a lot. So let's ask the questions. Let's go for the simple part. So I'm thinking a lot of stuff, but then I'm going to narrow it down when I complete all my evaluations. That will be the final diagnosis. When I get to the last thing, when I confirm due to exams and evaluations that this is what you have. That will be the final. We know we will not always get a final diagnosis. Sometimes we just stay with the differential because there are so many things and we don't know what it is. Just because we are doctors doesn't mean that we know everything. No, there are some conditions that are unknown. That's called idiopathic conditions. They are there, but we don't know what causes them. We don't know how to treat them. We just treat the symptoms. So that will be the 3 steps of diagnosing patients. 1, provisional, which is a temporary one that we make when the patient tells us the chief complaint. The other one is the differential. We have a bunch of things that we might consider it might be the problem because they share the same signs and symptoms. And then, the final, when we actually get the results and we confirm that this is the condition. Again, not all the conditions we have diagnosis for it. We don't. Some of the conditions we just treat the symptoms. That's it. Not much we can do. So that will be the diagnosis. Okay, any questions about diagnosis? Obtaining the patient's history. Now that can be done by the nurse, by the medical assistant, all depends on the policies of your organization. So most of the time, just to avoid any omissions, we rather not allow the medical assistants to do it because there are some conditions that might be, or some of the chief complaints that might be a little complex for the medical assistant to do it. So we just ask them to check, just report the chief complaint, and the medical doctor actually collects the rest of the information. So that's basically what it is. So how do we obtain the history of our patients? Well, by asking the patient, right? That's what I've been saying all this time. So patient's questionnaire. Now we can have a template that is based on the symptoms, the chief complaint, or we just ask the questions. We might ask the patient just to check anything that they think that they are feeling. And they see things as, oh, fever, yes. Oh, headache, yes. Body ache, yes. Cough, no, this and that. And then we have an idea of things that you bring, and then we start asking questions directly. See, medical assistant asking the patient questions. So you can complete a form, but just because you completed a form does not imply that this is it, that that's everything that we need to collect. No, it might be more. Maybe the patient didn't tell everything that we need to know. Now we have other questions we know how to ask. Then next step, the physician is going to ask the patient. Remember, the patient tell you, we ask them to fill out one of the questionnaires. We'll read the questionnaires. There are some questions they are left blank. We're going to go over those, so we're going to ask. And then when the patient goes to see the doctor, well, the doctor is going to see all that information that was given by the patient, but was elicited by the medical assistant. Now I'm going to ask more questions based on the information that I have. Why do we do that? Because that saves us a little time. We already know these questions that I'm going to be asking as a medical doctor has been already completed by the patient with the questionnaire or by the medical assistant who elicited these questions. So that's basically what it is. Now, there is always a combination of all these type of history taking. Why? Because it helps us. The more information that we gather from the patient, the better outcome for the patient. The more you know, the better, right? So that's basically what it is. So if the patient omitted an information, the medical assistant might ask certain questions that were not responded by the patient. And whatever the patient didn't respond with the question through the questionnaire, and the medical assistant did not ask the patient, the physician is going to do it. So that will be a combination of all these types of techniques, so to speak, used to obtain the patient's history. Very important, very useful. So that's how it works. Okay, so it says right there, medical assistant role when taking patient's history. Now, I just want to clear this up. Remember, you might not be taking patient's history. My best advice to you, when you start working in a place, ask the person that is your immediate supervisor, or even better, during the time of the interview. But if you forget about all this because you are so excited in getting a new job, probably you're not going to ask. Well, when you start working, ask your coworkers. Ask them, ask the office manager. Oh, by the way, when a patient comes in, do we take the whole history, medical history, or we just write down the chief complaint? Oh, by the way, you don't do any of those. You don't check the chief complaint. You don't ask the patient for anything. You just, register the patient, and that is it. Oh, good. No, you have to do only the chief complaint. Or we have a questionnaire right here. You give it to the patient. Make sure that, you offer your assistance to the patient if needs something to be clarified within the questionnaire, or if they're having any issues, and if the faculty is trying to complete it. So make sure that you assist the patient. So that's what you have to do every single time that you get a job. Get familiar with the policies of your organization. Don't assume that it goes exactly as the classes went. Some of the things might happen, some of the things might not happen. So again, just for you to be mindful of all these, techniques and processes that goes along with patient registration, patient submission to your facility. Take a history and a physical location that ensures patient's confidentiality. I mentioned this many times. One of the things that we have to do when we ask questions to the patient is we're going to use certain tone of voice. Remember, this was communication, effective communication with patients for those who took the class with me. Remember, everything is going to come together. So all the classes, all of them are going to come together because that's what, we are going to be doing. So the most important thing is, you're going to lower your voice. You're not going to whisper, but you're going to talk in a tone of voice that, not too fast, not too slow, that the patient can understand, but at the same token that, this information is not overheard by, bystanders or the patients that are in the waiting area. Because there is always patients around, always. So you're going to make sure that when you ask the patient, you are very discreet, sensitive. And if the patient has some sensitive issues, then you take them to an empty exam room or to the lab, anywhere where you and the patient are going to be alone. So you can collect this information. Sometimes the patient do not tell you anything because whatever they're going to tell you, it is sensitive in nature. So they're not going to tell you. If the patient is kind of whispering to you something, do not bring to the attention of the patient to speak louder because that is inappropriate. Probably they don't want anybody else to hear but you. But now you're not understanding the signals that the patient is giving you. Take the patient to a separate room. Mr. and Mrs. Brown, let's move to a private room, okay? Let's take the information over there. Tell them. They're gonna feel really comfortable. Well, they're gonna feel very comfortable from the moment that they step into the office and stand right in front of, the counter, because you're gonna greet them in a nice, professional way. Good morning, good afternoon. How can we assist you today? Oh, this is Alberto. I'm the medical assistant. How can I assist you today? What brings you today to our office? Make them feel good from the beginning. So then they're gonna be comfortable with you. They're gonna be telling you things. Other than that, they're gonna tell you, oh no, I'm gonna speak to the doctor. Well, let it be. So if the patient doesn't give you the information, you just let it go. Do not force the patient. No, 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 you have to tell me. I have to write down what is the reason, otherwise the doctor is not gonna see you. Or when you decide to give me the information, then, I'm going to register. No, that's not the way it goes. Remember, patients have the right to refuse anything. If I don't want to tell you what is the reason that I'm here, that's how it's going to be. And you should not take it again. You should not retaliate against me. You have to be as nice as possible. Okay, sure, not a problem. Please have a seat or whatever it is. Don't take it personal. If I don't have to write lots of information, good for me. Why do I want so much work? Less is more. If the patient doesn't tell me much, well, there are less work to do. I move to my next patient. I just do the things that I have to do. I just did my part. If the patient doesn't want to tell me, not a problem. If the doctor asks me, why didn't you record or place the entry for the patient's shift complaint. Oh, the patient says that, she will discuss that with you only. I respect the patient's privacy. That's how you're going to defend yourself. Oh, the patient was very angry. The patient didn't want to tell me anything. Well, you have an attitude. Probably that's why they didn't tell you anything. No, you have to be very, very professional. Whether the patient was with an attitude, upset, combative, offensive, anything. No, you should not change because the patient is like that. The patient can tell me anything. Well, not the patient, anyone. Do you think that I'm gonna get upset and start arguing for that? Hey, talk. I'm not gonna get upset. Oh, please do not touch me. When you get physical, things change. But anything else, you can say anything. I'm at work. This is not the place where I live. You're not gonna come here and mess with my brain. No, you're angry. You have your own issues. I understand that because I'm very empathetic. That's it. I get someone else to help me out if I can deal with you. That's it. But I'm not going to get into confrontations with no one because I'm the only one who's going to be losing. I'm the one who's going to be stressed out. I'm the one probably is going to get fired. No, not at all. Just relax, take a deep breath, and move on. If you ask questions, you have to ask open-ended questions. Now, again, what is an open-end question? Something that leads to get more information, that get more details about the reasons or whatever I'm asking the patient. Oh, so you said that you have fever, right? Yes. Oh, well, that's not an open-end question at all. So what is, on a scale 1 to 10, how would you rate your pain? 5. That is not an open question. What brings you here today, Mr. and Mrs. Brown? Oh, you know what? I'm having this pain. It's so bad. I cannot do my daily activities. I just to do this and that. That's an open is you giving the chance to the patient to give me more details because that's what I want. Sometimes we want open-ended questions. Sometimes we want closed-end questions. How old are you, Mr. Brown? Well, I was born. Wait a minute. That was in the time of the war. We don't need to know that. This year, I'm this old. This is my age. Because it's needed. What is your address? What is your telephone number? Those are closed-end questions. But if I'm asking you, what's the reason that you're here today? Now you can start telling me what the problems are. You give me details. So that's basically it has to be open. And you need to know because the most important thing that you have to know is what is an open-end question and what is a closed-end question. Because you're going to be asked in the exam. Oh, you definitely going to be asked. So which of the following is considered an open-end question? So you gotta look when it says, oh, they ask for your day of birth. They ask for your phone number, for your address. Those are not open. These are closed. These are definite definitions. My age. Oh, I'm 50. Oh, well, you didn't give me anything else. Your telephone number, 5555. Oh, okay. Close. But when I give you the opportunity to get me more, then that will be the answer. Remember, I use all the time the process of elimination. Oh, believe me, it works wonders when I'm taking a test. Process of elimination. I look at the answers and I think to myself, okay, this is definitely not what they're asking me. This is not definitely what they're. I'm in between this and this. Because there is always something that is telling you that is not it. That has nothing to do at all. I discarded. What should I keep it? Have it as as an option. I do not even consider. So these are the open-end questions. Again, when you elicit more details. So that's basically what it is. Close, remember when they ask you about something. At what time do you get there? 11 a.m. That's close. You're not giving me more details. Remember, when it comes to what is your name? And they tell you a name, that's a close one. Okay, so you said that you have headache. Can you tell me a little more about the headache? How's the headache? For how long it's been going on? Can you kind of go over that to me? That's an open-end question because you are eliciting more information, more details. So keep it in mind, open and close-end questions will be on your exam. And once again, they're just going to give you examples of what, the options are samples of these conversations, this type of questioning or questions. Authentication. So we're going to use authentication everywhere with paper-based medical records and with electronic medical records. So it says right there, for the content of a chart to be admissible as evidence in court, the person dictating or writing the entrance might be able to attest that they were true and correct at the time they were written. Well, that's a lot of stuff right there, right? So, wait a minute. How do I know this is authentication? No, authentication actually means that you, the person who entered this information, you sign it. Your signature is there, whether you wrote it down or it is an electronic signature. Everything that you enter there, you know that for you, it is a fact. And nobody else can change that. That's why medical doctors, when they complete the history of the patient evaluations, when they complete the medical records for that time of the visit for the patient, they have to sign it. That's why medical assistants, when they complete a blood work, each tube has a label, you have to put your initials. If you enter right there the chief complaint, you have to put your initials. Who did it? Who collected this information? Remember when we did the EKG and the blood for those ones who practice with me? We did that. That's authentication. I'm signing what I did because this is my information and I did it. I placed this entry. I collected. With that being said, to never sign anything that you have not collected, done, documented. Listen, very careful. Never sign anything in your well, you should not be signing anything at all. In the medical, it's very dangerous. A nurse can ask you, oh, listen, this is done already. Can you sign? Oh my God, I left. I forgot to sign this document. Can you just put my initials for me? Don't do it. If something is wrong wherever this nurse, this doctor, your colleague, another medical assistant, anyone, whatever they did was wrong, they're going to blame you, not them who did the mistake, because you are testing, you are authenticating that you are the one who entered this information because you signed for it. Remember, when you enter into a contract, you purchase a car, a phone, anything, a rental agreement, and you put your signature right there, who is liable? Who's responsible? if something happens. You, it's your name, it is your signature there. So you shouldn't be signing anything just because somebody asked you to sign it, even though if it is the doctor. I'm so sorry, doctor, nurse, medical assistant, colleague, whatever the case may be. I'm so sorry, but I'm not gonna be signing that because I didn't place the entry myself. You know better than me. You should tell them, you know this better than me. I'm not gonna be signing that. Sorry. That's it. It's a legal issue. It's better that you fire me, whether you get me into trouble. Because remember, in the court of law, it doesn't matter who ordered you to do something. If your signature is right there and something happened, bad happened, you're done. So there is nothing else can say with it. Remember, every single time that you collect blood, the requisition form, they're gonna set technician, operator, you put your initials. Medical assistants don't sign, they use initials. Doctors sign, medical assistants don't. So you're not putting your name there, your signature right there. No, you're gonna put your initials. The first letter of your first name, the first letter of your last name. That is it. If they assign you a code, because in hospitals sometimes they assign you a code because it's for privacy purposes. Well, they're gonna use your code every single time that you complete something that was assigned to you. That is called authentication. See, it can say a lot of stuff right there, but the truth is very basic. So whenever you enter information, you record information, you document something, and because you did it, and because we assume that you did it with, following all the policies and training that you probably have according to your credentials, well, you're gonna sign it. So putting your initials, in your case, that's signing. Putting your code, if you were giving one instead of using initial, that's signing. The doctor sign it, well, putting their own signature. So be careful. The same way that you're never gonna share the patient's information with anyone, you're not gonna sign any documents. You're not gonna correct any documents from anyone. I'm telling you, I've seen so many things in my workplace, in my all years of experience, that sometimes you wonder how is this possible? Just because the doctor asked me to do something? No. If it is not within the scope of duty, if it is not something legal, something that I know I shouldn't be doing, but just because the doctor asked me, because the nurse asked me, just because I'm afraid to lose my job, I'm gonna do it. Well, you're gonna be losing more than your job, because you will lose your job anyways. And then probably you even end up in jail. It's not worth it. I will say no every single time that somebody asks me. I said many times. I was threatened. I was retaliated. Oh, if you don't do this, you're a doctor. You're supposed to do it. Do it. I said, no, I'm very sorry, but that's not the part of my scope of duty as a medical doctor. No, I'm not going to do something. Well, the patient is going to die. You're going to be sued. Well, if the patient dies, there's nothing I can do, but I'm not going to put my hands in there because I'm not qualified to do something. Why should I do it? Just because you're telling me? Just because you're forcing me to do something? No, it doesn't matter who tell you. If it is something that you're not aware, you're not sure you should be doing, you just don't do it. Or something that you don't feel comfortable doing, don't do it, because listen, chances are things will have a bad outcome. Just don't do it. So this is authentication. Now, what am I going over all these stories that I'm telling you? Because this is the real world, and this is what you're gonna be you're gonna be facing all this. And questions in your exam are just like that. The medical doctor asks you to do something, and then you did it. And it turns out that that was not bad. The excuse is like because the doctor asked me to do it. No. If I ask you to jump into the train track, would you do it? Oh, no, I would not do it. But yes, you put the patient in this situation. Now you're in trouble. Again, just because you don't see the consequences, because most of the consequences are unforeseen. But I know what is my scope of duty. I know what medical assistant should do. I will not go beyond or below my scope of duty. Let's see. Let's go over making additions to the medical records. So there are two ways of making additions to the medical records or making corrections. So when we add in something to the medical records, remember we have these files, these loose papers, because we have paper-based medical record. Well, you have to go there and place this paper, this document, in the section that belongs, number one, and within the date and the time that it was issued, it was recorded, it was documented. You don't just put it anywhere. When it comes to the progress notes with the lab results, remember the latest lab result that we did, if it is a blood, it's going to go on top. Remember, this is a reverse chronological order. You've seen this like 100 times through these chapters. Why is it that I have it so many times? Because this is a question for your exam. So if I put it just once, or I write it down once, and I just mention it once, what are the chances that you're going to forget this? 99.9%. But if I'm saying it over and over and over, and you see it, well, guess what? It's going to stick in your brain. Because this is the way that we file documents in the medical records. We use a reverse chronological order. That means that the last evaluation, the last notes, the last laboratory is going to go on top. So remember, reverse chronological order. The last part of this evaluation is going to be put on top, period. And that's called reverse chronological order. Now, before we file these documents, I mentioned it already, it should be already signed, authorized, meaning the doctor have read these documents first. But remember, every single time that you receive a lab result, anything that comes by mail or a document or a medical record, before you put it back on the shelf, open it up. Oh, progress notes. Doctor didn't sign. I'm not placing it over there. I'm going to bring the medical record to the medical doctor. Oh, Dr. A, B, C. Oh, I was going to file this medical record and I look at it and you didn't sign it. Oh, just sign it whenever you have some time. Don't tell them, oh, sign it right now. Remember, this is your doctor. Even though if the doctor is friendly to you, is nice to you, don't take that for granted. Always keep professionalism, respect. These are your superiors. So don't think that because the doctor is nice to you now, oh, well, we are buddies. That's not the case. Some doctors are just nice, but don't go overboard. I seen it. So be careful. Just with all the respect, doctor, here I have the medical record. You didn't sign it. So whenever you have time, sign it, or let me know when you finish and I pick it up. Listen, the doctors come over and they drop it off on your counters. They give it to you because that's what we do most of the time. Again, all these forms has to be, read by the doctor prior for you filing them. Can you imagine you filing a blood result that has some red flag tests, high results, or the patient is at the risk for something and you file and the doctor didn't know? And the doctor is going to find out later on when the patient comes for a visit or when the patient when the patient goes to the emergency. That's going to be a bad time. So being a good, medical assistant is not like every single paper that comes into our office. Oh, I'm going to file it. I'm going to file, and I'm not going to leave any paper loose. No, you're going to place it in the bin where are, things to be signed, and then pick down from that other bin where it says to be filed. Remember, you're going to follow that all the time. Otherwise, you're going to get in trouble. So if you see the document that is not signed by the doctor, it's not being reviewed. So then don't file it. So again, it says right there, some offices direct only abnormal reports to the physician. That is false. Every single report has to be read by the medical doctor who ordered that test, regardless. Oh, because it's abnormal, then, it's normal, then I'm going to file it. No. Every single document that comes to the office that has to be seen by the doctor, put it in the bin for a review. That's it. That's got to be in standard. Follow the office policies as to which method is used in that particular office. I cannot stress enough because this is a question for exam. You're going to follow the policies of your organization. How the medical assistant know what to do? Because they're going to follow the policies of the medical office. Period. That's basic. That's how I want you to think about it. Don't ever do anything that you think that might be the right way to do it, or the way that you think that you have seen someone else's do it. No, make sure that you read, the policy manual. That's where all the office policies are. And they have one binder right there with all the information about all the regulation that goes in that particular practice. 90% of the medical assistants read this binder, this policy manual. 90%. Can you imagine? Only 10% read it. Again, very important that we follow things, by the book, because that can, get us in trouble. After you do it once and that was the right way, well, you keep on doing it that way. But don't assume, don't use shortcuts. Oh, I get it. Oh, no, I know how to do it. We are sometimes very overconfident. Remember that. Overconfidence is not good, and not having confidence is not good. Nothing, see? Has to be balanced. You cannot be overconfident. You cannot be not confident. Because if you are overconfident, then you think that everything that you're doing is good. That's what you make mistakes. And if you're not confident, well, you're not going to do it because you don't feel comfortable. So you're going to make mistakes. Okay. So it's 7 p.m. We're going to take a break. We're going to take 30 minutes. And when we come back, we're going to wrap it up with this chapter. And that is it. Okay? Enjoy it.
Okay, teacher.
7:30. Remember, we're gonna meet back again here in class. Enjoy your break. All right.
All right, thank you.
Thank you. Okay, so we're back. Okay, so we're gonna continue with this chapter, see if we can finish it today. Okay, so let's see this, describe this image right here. So let's see, this is 7:30, yeah. Okay, here we can see a medical records and it is sections. So that's how it works. So in this first section, we have the patient registration form. See, it has all the information right there that the patient needs to know regarding the content of this medical record. What is written here is the statement that the patient is obliged to pay if the insurance doesn't cover the entire cost of the services or the procedure. Also, we read right there, or it is written right there that if that the patient's information is going to be released to certain people who works for the office, who's taking care of the patient. So that's basically what it is. Has the patient rights. Also, he explains there that, there are some forms that, needs to be completed in case of releasing of information, that all the information is going to remain confidential, private, and secure. So that's basically what it is. And the patient signs right here. So here we have all the information. So these are the sections. We have one section for the patient's personal information. This is the registration form. So here we have other information, maybe the billing, what the patient pays, or the insurance information, and then the progress notes right here, and the labs and everything else that we need. So that's basically how the medical record is divided in certain sections when we are going to place the patient's information and this reverse chronological order. That's basically what it says. Every single medical record, you're going to find it in this fashion. So it's not something that is going to be used in different scenarios. No, it's for every medical record. So that's basically what it is. Laboratory results. So in fact, what we're covering here is all the sections, what goes in each of these sections of the medical record. When we talk about laboratory reports, we're talking about everything that is done to determine what the patient has. So these are all these tools that we use to make sure that we don't miss any issue from the patient. So sometimes we just need these lab results to confirm a diagnosis. So it has to be ordered and it has to be collected accurately. So we can have accurate results. Otherwise, well, we're going to have problems. Are these lab results all the time going to tell us exactly what the patient has? No. So not all the time. Most of the time, we're going to get results. Some of the times, we're not going to see anything. So we have to reorder something else. And sometimes we just get the negative results. All the results are good for the patient, but the patient's still feeling sick. Remember, there are some conditions that we do not know diagnosis, that we don't know how to treat it. These are called idiopathic conditions, and it's very difficult. That's how it is. So we don't have any documentation on these conditions. So we just treat the symptoms once again. So this is one of the laboratory results example. This is blood work. Remember, laboratory means blood means urine, means feces, means amniotic fluid, means seminal fluid, means vaginal fluid, means biopsy, means anything that is removed from the patient's body, which is considered a body fluid. So that's basically what it is. That is one part. The other part is the imaging reports. Now, CAT scans, MRIs, sonograms, EKGs, any printout that we get for a test that we do, that's going to be laboratory. Again, we have to have all these laboratory tests done on our patients because that's what's going to aid us to get the results, to get the diagnosis with those results. So that's basically what it is. Radiology reports, remember, this is where, but all are laboratory reports. So we're going to separate them in between labs for blood, urine, and so on and so forth. Now, radiologic reports, CAT scans, MRIs, you name it. So that's basically what it is. Now, we are not talking about the film, the actual X-ray, the actual CAT scan. No, we're not talking about that. We are talking about the official reports. So if we order blood, the results are going to be printed out in paper. It doesn't matter the size, but most of the time it's just letter size. So that's basically how it is. So these reports are going to be done by the person who evaluates, who analyzes the results based on all these standards and all these well, I have a name for it, that based on all these patterns about what is considered normal, what is considered a normal high, a normal low. That's basically what it is. So we have some standards, and it's going to be interpreted by the microbiologist, it's going to be interpreted by the radiologist. It's not the regular doctor that is going to be doing that. Whoever specializes in reading these particular laboratory reports is the one who's going to do it. So again, if it is blood, if it is urine, if it is feces, it's a synovial fluid, that might be the chemistry doctor or the chemist, or it might be the microbiology doctor, it might be the pathology doctor, whoever is specialized in that particular type of analysis of those tests. Radiology reports has to be read by a radiologist. So we're going to receive not the film. Sure. We're not going to receive that. What we're going to receive is the official reading. So what's going on that is documented by the radiologist. So that's basically what it is. See, as a medical provider myself, emergency doctor, yeah, I can see, I can order an X-ray, CAT scan, MRI. Yeah, I can interpret some of the things, but that's not what we're going to do. It has to be interpreted by the radiologist. And when it is interpreted by the radiologist, we're going to follow what they interpret. The results that they get is what we are going to be using to go for the treatment, for the diagnosis. It's not what we decide. This is done by the specialist. Remember, there is always a specialist. And if the radiologist make a mistake, that's their fault, not me. I received the results from them. Remember, each doctor is specialized in something. We are not specialized on that. We are specialized in my field. We are specialized in trying to, sustain the patient's life. That's basically what it is. In a kind of, get the patient stabilized. That's what it's called. And then we pass this patient to whoever, specialist is going to be treating them. If it is the heart that the patient is having problems with, it's going to go to the cardiologist. If there is anything related to the digestive system, it's going to go to the gastroenterologist. If it is the nervous system, we're going to pass this to the neurologist, and so on and so forth. So we just like the middle people right there, because we have certain responsibilities, and that's it. We don't go beyond that. We're not going to do somebody else's job, because that, remember, is working without license. So that's how it happens. Usually type on standard size stationery. Well, this is just a letter size, paper, placed in reverse chronological order with the most recent report on top. See, reverse chronological reverse, and the most recent on top. This is how we are going to document everything. This is how we are going to file everything on the patient medical record. So that's how it works. Medical records often have a separate section for laboratory and radiology reports. Of course, for everything, we're going to have a section. For the medical providers, when they write the notes, it's going to be one section. When we place bloods, when we place urines, when we place anything else, it's going to be their body fluids. Radiology reports, they're going to go where it says radiology reports. In CAT scans, go where CAT scans are. In X-rays, where X-rays goes. Sonograms, where go where sonograms are. We don't mix them up. We don't mix blood with urine, with feces, with synovial fluid, with biopsies or seminal fluid or vaginal fluid. None of those. Each one have a section within this laboratory part. That's how it works. And that's how it's going to make it easy for us to retrieve it. Can you imagine all these urine, feces, synovial fluid, all those reports together? So when we're going to look for it, we have to kind of flip to every single page to find it. Then what is the purpose then of organizing this? There is no purpose. There is no means. So for that reason, we have to separate them by each one of the types of. So if they ask you, okay, can you please get me the CAT scan from this particular patient that was done in this particular time, you just go where are radiology reports and then go to the section when you have X-rays, CAT scans, MRIs, depends on what it is. And because they are filed in reverse chronological order, well, you're going to see the first one and it says, oh, that was done in June 2024. And they're asking you in January 2023. Well, you're just going to go back. Not going to go forward because there's nothing there. Because the latest is going to be on top. So anything else is going to be behind that. So that's how you're going to be filing and retrieving all these documents. That's what's going to make, everything easier for us. Other than that, we just pile everything together and then spend hours trying to filter through or scan through all these papers to find whatever we need. Progress notes. Now, progress notes where, the progress notes are. Usually the progress notes, not usually, all the time, are written by the medical doctors. So what is it with the progress notes? Remember, for the progress notes, we use the SOAP note, the SOAP, subjective, objective, assessment, diagnosis, and plan treatment. That's how we do. And every single time that the patient comes in for anything, we're just gonna add the information to another page. Can we use the same progress note to write twice the visit of the patient? Well, let me clear this up. Probably you don't understand what I'm trying to tell you. So let's say that we have this page right here, right? The patient comes in today. So today is 11/19/24. So the patient says, oh, well, I'm just here for my lab results. Lab results. So results from the lab. So that's all the patient wants. So what about any other information? Well, the whole page is going to be blank, right? So just have this information right here. Can we use the other part of the page to write another note for another time that the patient comes in? Of course, we're going to do that. If there is enough space to fit here information, the SOAP. So here we're going to put the chief complaint, here all the evaluations we're going to do, here we're going to say the diagnosis, and here whatever we order for the patient. Yeah. Now, it is mandatory to do that? No. There is a penalty to do that? No. If you don't want to write now anything in this page, or you don't have enough space, you're not going to start something right here and continue on the next page. That is not acceptable. I cannot write, okay, SO, and the AP goes on the next page. It doesn't work that way. So if everything fits, we're going to do it. Otherwise, what happened to this blank space right here if you use in another page? You cross it out. You have to. The medical doctor cross the blank space so no one else can enter information there. Remember, this is done for security purposes. Somebody, let's say the doctor forgot to do something and then they added to it. Even though if it happens later on. So let's say that the doctor forgot here to enter some information. Well, that's not how we add information. Then you have to create another note with another date, not to add something and assume that everything was done the same day. So for that reason, as soon as I finish with something, or I assume that I finish, if I'm gonna leave this blank because I'm gonna start another progress notes with my patient next time, or I don't want anybody else to write anything there, I just cross it out. That's it. Because I don't want anything to happen. Remember, I'm giving space to someone to enter something and probably get me in trouble. So I eliminate that. Remember that the medical records can be used by different doctors. It can be pulled out by a nurse to give medications, to read the orders. And then at the same token, they can enter some information. And if they enter some information they're not supposed to, well, it's going to cause me trouble. So for that reason, I cross it out. We have to do that. So if the nurse enters there just to get some information, you just go there to get information, not to add anything. So for that reason, I cross it out. Nobody else can do anything. So right here, let's say, for instance, see, right here, this space right here of the progress note. I wrote all this information about my patient. I'm not going to leave this blank. I cross it out. So if I cross it, if you enter information, it was crossed out. That means that someone else added after I complete it. It's not valid. So it's forged, not good. So that's basically what it is with the progress notes. That's when we are going to document all the information about the patient. Patient chief complaint, what did we do? To find out what the patient has, we're going to write down all the objectives, all the examinations, all the procedures, the tests that we order. Then we're going to have a diagnosis and then treatment or plan. So that's how it works. So this is the progress note. Now, this is the subnote. Here we take the history of the patient. So we saw the subnode there because we can have a subnode that is actually tailored, customized. It's a subnode, so S for subjective. Here, we just follow the same pattern, but we have to write down SOAP. And that's how it shows right here. Here we have the S, the O, the S, the O, the A, and the P. So that's how we enter the information. And most of the progress notes looks just like this. It is a blank paper with all these, marks and spaces when we're gonna write down the time, the date the patient was seen, see? And what the patient told us. We're gonna recommend all that information that's done manually. Then what is it that we did? It is here, the objectives, and then what was the diagnosis, and what was the plan. So that's how it is. So in this case, there were two sides, two visits, right? So here I cannot because they have plenty of space. But if I don't want to write anything down or I don't want anybody to use it, I just cross this. And then when I'm gonna do it, I start another progress note. So that's basically what it is. This actually, well, we don't do it colors. We have, they are standard white color. But they just, give this an example of the progress note. But it doesn't matter the color, but usually it's white. And right here it says progress note. And that's what we're going to use. Let's talk about how we are going to make corrections in a paper-based medical record. So be careful with this. It's going to be a question right here, 100%. First, verify the correct procedure as detailed in the policy and procedure manual. So again, we got to read the procedure manual because of the policies that we have to follow, how to correct errors. So one of the things that we should not do, pay attention to this, because here a question, for example, on this page. Never use correction fluid. You don't use correction fluid. White out. Oh no, I'm gonna white out and I'm gonna just write it on top, on the bottom. No, that's not how it works. We're not gonna erase. No erasing things. Number one is pen. How you can erase it? With the eraser and then start scratching then making a hole in the paper? I don't think so. It doesn't work. You should not obliterate the paper, meaning you should not go do like this, trying to hide what is behind. So again, not good. Do not try to hide the error, doing anything just to make sure, like, oh, it didn't happen. So we kind of fix it up, try to, go over the letters and try to fix it up, all the numbers, the values. Oh, that looks like a 9. Oh, no, let's do another little circle down. We put an 8 or a 6. So don't go over those things, try to fix it, because that's not how it works. Because that affects the credibility of whatever it was written, whatever information it was entered. And if you use white out these correction fluids, then you try to hide something. That's what you're trying to do. If you obliterate, kind of scratch all over with ink, you're trying to hide something. So in the court of law, that is a negative for you, for the practice. Oh, you're trying to hide something. That's what you erase it. That's what you kind of white it out. Now you're in trouble. Even though if it is not, only the person who makes the entry, who documents this information, is the person that is going to be correcting the error. And when you correct the error, you're gonna place the time, you're gonna document the time, the date that the error was discovered. It's not the time when the entry was done. Unless the entry was done, then you realize, you read it and you realize that you make a mistake. Now you do the correction. So again, if you make errors, then that's not going to affect only the practice in the case of a lawsuit or litigation, but also it's going to affect how we treat the patient because we just wrote something that was not right. So if I'm not the person, or maybe I'm the same person that wrote the mistake, I'm going to be based on my diagnosis, my treatment on those errors. And if it is someone else who is using it, not me, it is another doctor, well, it's going to make the same mistakes because we trust what this medical doctor actually documented because those probably were a accurate findings. Remember that the information has to be accurate. But if it's not, it's going to affect the practice, the medical doctor, the patient, everyone. So then how we are going to do that? Well, very simple. We're going to follow these 3 steps. We're going to draw a single line through the error. So you see right here, we have an example. Right here. The name of the doctor was entered wrongly. So someone asked certain doctor to review this particular chart, let's say the way of this particular diagnosis. And when he made the entrance, put somebody else's name or enters the wrong diagnosis, the wrong medication, the wrong day of the procedure, the wrong name of the procedure. Anything that we make a mistake, what we have to do is we just cross it out, just draw a line. See, draw a single line through the error. If it is true and it wasn't true, it was thought, oh, made a mistake. I know that if I just draw a line over the word, I'm going to be able to see what was it before. And then what is it that I'm going to do? I'm going to spell it out right here correctly. It wasn't true. It was thought. So then I'm going to put that right here. Then I'm going to date it. Today, 11, 19, 24. And I'm going to initial it. AH. That's it. It's done. So that's how we have to correct. The correction can be done on top, on the bottom. You can put the information wherever you want, but it has to be right there within the word. So we're gonna insert and write information. We're gonna date it, and we're gonna initial it. Now, if it was the doctor who made the mistake, well, the doctor is gonna sign. So you cannot, by no means, do it differently because we need to know what was behind, what was written prior. So you're not trying to hide anything. So that's basically what it is. Remember, in the court of law, or for someone else who's trying to, follow the patient's care, And if it doesn't see the information how it is, if it sees something that is obliterated, white out in a medical records that is a legal document, that kind of, may make suspicious that something might be going on. So that's how it is. Those are the rules. Those are the regulations. So remember, if you don't do it this way, then if something happens legally, the person who did that is going to pay the consequences. Remember, in the court of law, everybody's going to go down because you're going to be found guilty because you just didn't follow the proper procedures. You just decide to do it. Now, sometimes, back in the days, you had to write down correction and then do the correction. You just write down the entire word as correction. Correction, it wasn't true, it was thought and dated. So either or. So when you ask, because you're going to be asked, not exactly all this information, but when you've been asked about how to correct, and they're going to tell you, they're going to give you the information, what is the proper way to correct information on the paper-based medical record? Or there's nothing else, just how you correct an error in the medical record. Draw a line through the error. That's it. That's the key. You're going to draw a line, single line, just one, because you're not trying to hide anything. Anything else is just, irrelevant at this time, because none of the other answers are going to have to draw a line. That's not draw a line, write this, write this, write this. Draw a line through it and do it. No, that's not like that. These tests actually are not trying to get you. They're not trick questions. You are the one who's going to trick yourself. And most of the time, they are kind of straightforward. They can put things that are very similar to it. So you can kind of, oh my God, is this word? Is this that? It sounds like the same. It looks the same, but is it? No, they don't play around with that. They tell you one thing and the other ones are totally different for whatever. They're going to say, oh, you're going to white it out. Oh, you're going to erase it. You're going to delete it. No, you're going to draw a line. That's it. Back in the days, we learned that when we draw a line, it has to be a red line with a red pen. There is no way that we're going to use pencil for this. Now it's just to draw a line through the word, and that's it, through the arrow. That's it. Do not worry about being red, blue, black. It doesn't matter. So that's how it's done. Remember, the date that you have to enter there when you do correction has to be the date that you are making the correction, not when you wrote the entry, when you document it. And only the person who made the entry is the one that is going to do the correction. So let's say that you are asked to do an EKG or draw blood from the patient or do a referral, because now you have to go through certain information from the patient. You open the medical record and says, oh, send the patient for a CAT scan. But then it turns out that the diagnosis is not requiring a CAT scan. So then it says it's a radiography, X-rays that it was supposed to. The doctor wrote CAT scan, make a mistake. What are you going to do in this case? You see their CAT scan written in the order, but in the medical record appears or shows that it is an X-ray. So what would you do in that case? You're going to go to the doctor. Oh, excuse me, Dr. A. I received this order to send the patient to do a referral for CAT scan. But when I was reading for the diagnosis, it says right here that it was an X-ray that was supposed to be sent out. So that was the plan. So within the plan, it says X-rays. and then, but you wrote a CAT scan. Is that correct or am I wrong? You make it look like, oh my God, I'm so smart. Oh my God, I know more than a doctor. Oh, this doctor was supposed to be right. That is not the point. We make errors. We have so many things in our heads. We see so many patients. Sometimes we don't document when we're supposed to document because, there are other things that we want just to finish with the patients and we want to leave the documentation for later. That's when you forget. That's what you have to document everything as soon as you're collecting the information. That's it. You cannot wait until you see all the patients to sit with all these medical records to start completing the patient's history or the findings. No, we go and complete them as we do them. But this can happen. You can be nice enough and go there to the doctor and make sure that you tell the doctor because you're going to give a referral to the patient for a test that the patient is not needed. That's not. So you're going to look really good without showing off. Remember what I told you when I prescribed medication from one of my patients in the emergency, and the patient was allergic to it. When the nurse was going to give the medication, the nurse immediately opened all the information because she has more information than I do. So she went over stuff there in the computer and says, "Oh no, wait a minute. Patient is allergic to one of these ingredients, so to speak, one of the components of the medication." And she came to me. I said, "Oh, I'm sorry, Dr. Hoyer, to disturb you. I was going to, complete the order that you gave me, and but I noticed that you prescribed this medication, right?" And then I said, "Yes," and says, "Okay, so the patient is allergic to this." And just because the medication doesn't say exactly what the patient is allergic to, one of the ingredients, one of the components of the medication that I prescribed, I was new. I'm not know it all. But the nurses, they know when it comes to medication, the nurses knows more than a doctor. That there is no question about it. She noticed that she came to me very polite, very, very professional, says, the patient is allergic to this medication. Maybe, you can go over and just get another medication. Oh, let me know when you're ready. Sure, that was my priority. Go fix that immediately. So again, I didn't have to correct anything in the medical record because the medical record was okay. The order that I gave to this person to go there it was wrong. It was just the order that I gave them. So that's basically it. So again, you have to work as a part of the team without, making other people putting them down. So I know people that do that. So you as a medical assistant should not do any of this because it looks really bad on you. And don't start going telling everybody, oh, you know what? I caught something that I noticed that this doctor did wrong. How smart I am. Because remember, these are gossips and these are not good comments. And eventually you're going to get in trouble. So again, be nice, work as a part of the team, things happens. So I'm there for you. One day they're going to be there for you. Somebody's going to be helping you. Remember this, everything is about the patient right here. This is not about the doctor. This is not about the nurse. This is not about the medical assistant. It's about our patient. So again, this is how we are going to correct errors in the medical record. Remember, this is paper. Now, look at the difference right here. How we are going to correct in an electronic medical records? Remember, electronic is typed, right? So you might think, oh, I can edit it, right? I can go back and remove that word and place the one there. No, not that fast. It doesn't work that way. When we document something in a electronic medical records or electronic health records, because we're going to talk about what is the difference of medical records, And electronic medical records and electronic health records, those are totally different two things. We will discuss that. But because we are entering the information using a keyboard, it's going to be print. Well, we might think that we're going to use all these keys from, the keyboard. I'm going to go there and delete it. Easy, piece of cake. No, not that fast. We cannot do that. Why? Because as soon as I complete the form, as soon as I sign that document, that history, that information, when I completed that progress note from my patient and I sign it, when I sign it, I click sign. Immediately, this information is going to become read only. So you cannot do anything but edit it, delete it. No, it doesn't work that way. So then how are we going to fix it? Very simple. We're going to go to the note. This is the note. And we are going to addend this. So we're going to do an addendum. So this is the page. This is the note that I enter. And I make a mistake. Let's say correct. It wasn't correct. It was incorrect. So I found this error right here. So I'm going to this node where I have the error. The page is going to have a pull down menu. It's going to be a little arrow right here. And if I click here, it's going to open up and it's going to give me information right here. Add more information. Edit information. Delete information. I'm just giving you a little something right there. So here it's going to say addendum. Remember, addendum, the ADD means to add something. But here it's going to create another note. So when I click addendum, then immediately it's going to show here a note when you're going to enter, when you're going to type what happened right there. So today's day, the 19th, 24, I'm going to do the correction. So I'm going to tell here, oh, instead of correct, it is an incorrect. So I'm going to add it right there. So it's not a correct test. It was an incorrect test or a positive or negative test. So here I'm going to do the corrections and then I'm going to click save, add. Think about text message. You got a text message from someone, right? Unfortunately, if you make a mistake, well, things have changed now with this technology. If you make a mistake on the text message, now you have a little time frame in which you can go there, click and edit it. Well, that is technology. But here it is totally blocked because this is a medical record. We don't want anyone to come here and try to fix it, to change it. Because it is what it is. It was the information that you entered. So then you're going to select addendum and you're going to enter. So let's say that you're going to respond to someone. Look at your message. Your message comes right here, sometimes one color, and this is the message that you send. The other message is going to come right here, smaller. And as many as you enter, now you respond, it is here. Then the other one, call it. So it goes in that type of fashion. Now you're going to act, and you can, of course, you're going to sign it. And that's it. Because there is no other way to correct it. So this is how it works. Remember, when you see if you have a medical records software, which 99.99% you're gonna have it in your workplace, you're gonna see how they do it. Now, you might not have to fix it. Maybe you have, because if you enter vital signs and you enter the wrong vital signs or the wrong information about the patient's shift complaint or whatever else you enter in the information, and if it is computerized, you cannot go there and try to erase it, delete it, because you're not gonna have that option. That option is gonna be there, but it's gonna be inactive, so you're not gonna be able to go there. And if you enter, you're not gonna be able to do anything because you're not gonna be able to delete because that key is inactive because it's been removed on purpose. So again, that's how you are going to create an addendum. So how do you correct electronic information? Well, you create an addendum. That's basically what it is. So it is an addendum. An addendum is adding something, adding a note to correct whatever you entered that was wrong. And the only person can go there and correct that is you, the one who entered, because you are the one who has the code. Remember, if somebody else tried to do that, they can do it. But then you're gonna use your code, you log in to enter to the system, and whoever do the changes on that particular day is gonna be registered. So if we go to the computer, experts, and we have someone who is in charge of all these computer systems. So it says, okay, listen, I found an addendum in one of my notes from my patient, but I never did it. Okay, no problem. We're gonna see who did it. That's the reason why you should not share your password, your login with anyone, because if somebody else have it, they can use it. Go do something against someone else, and then who's going to be blamed? You, because the person who chose there is not the actual person who entered in the system. It's not you. It's not the hacker who's going to show up. It is you, because that password, that login belongs to you. And if the one that shows up that opened this document, it was with your password, with your login, you're responsible. That's how it is. So again, be very, very careful with all this, because you can really, really get in trouble. Remember, patient's confidentiality, security, privacy, HIPAA. In HIPAA, you're going to be asked HIPAA, not what HIPAA stands for. It's what's the purpose of HIPAA. Okay, sharing your passwords with your colleagues, with anyone, is a violation of what? HIPAA. That's basically what it is. Leaving the medical records unattended is a violation. What violation you're incurring? HIPAA. Releasing the patient's information without the patient's permission. What violation are you incurring in? HIPAA. That's how it works. So everything that has to do with patient's information that is being released without the patient permission, that's violation of confidentiality. And who is regulating confidentiality? HIPAA. Privacy, HIPAA. Security in the medical records, HIPAA. Again, that's what we need to understand. Get familiar with all these terms that are so commonly used, and the ones that not because it's commonly used, because it's very commonly get us in trouble, and you don't want to be in that situation. So here is how you create an addendum. Now again, you have an error, so you gotta go, you're gonna select the patient, you're gonna be reading the information, you encounter the error, and then you're gonna click and you're gonna pull down the menu, and then they're gonna say, add a note, an addendum, and you're gonna correct it. That is it. So again, the note is going to appear right next to the text or the entry of the documentation that you have, showing what is it that you corrected. Now you all say. Now you see that here we find EHR. That is one thing, but then we're going to have EMR, electronic medical records, electronic health records. Oh, I thought it was the same. No, it's not. We're going to discuss that when we get to that chapter, because that's part of, see, this is just comparing how do you correct errors, how do you write down things in the medical paper, medical records, in the electronic medical records, and what are the advantages and disadvantages, because you have to use this comparison type of statements. Otherwise, just isolating one from the other, you're not going to remember. So we're going to put it together. But then we're going to go over some other things that they are completely irrelevant for the paper because it doesn't apply. But we're going to see the advantage and disadvantage anyways. Keeping records current. Now, again, these medical records, what do you mean keeping the medical records current? Meaning that all the information that is being entered in the medical record, anything that has been documented, has to be accurate, concise, brief, most importantly, complete. We cannot leave just pieces of the information that we collect from the patient. Everything has to be completed. The information that is there has to be legible. You got to use good grammar. Because other than that, even though if it is print that is legible, still you're not going to understand it. So again, every single laboratory for the patient results needs to be reviewed by the doctor and then filed immediately after being reviewed, but the doctor has to receive it immediately after we receive them by mail or any other form. See? Do not leave histories and reports to accumulate for long before filing them. That's what I've been telling you. You can't just pile up papers. Oh, lab results. This a letter from the patient, this referral, and all of these papers all over the place. So just put it in a drawer, just placing it one on top of the other. Well, that's going to create problems. Papers are going to be lost. They're going to be damaged. They're going to be misplaced. No, as soon as we get something, let the doctor review them. Let's file them. Get them out of the way, and we can refrain ourselves from, all these other issues that can be avoidable. Do not allow histories and reports to accumulate for long before filing them. Oh, well, we said that already. The patient's health is jeopardized when current accurate records are not available to the physician. Of course, we mentioned this before, the doctor needs the lab result. The lab results are not there within the medical records, or you didn't place them on the incoming documents needs to be reviewed. So now it's a waste of time. The patient came here for the results, but I don't have the results, and you don't know what they are, and everybody's looking for it. Wasting time. The doctor is wasting time. You guys wasting time. The patient is upset. Now we have a lot to discuss. Not good. Remember that the patient the medical doctor relies on that information in order for the patient to be diagnosed, to follow the plan, to collect information. Without this, things are not going to go well. And remember, if the patient doesn't receive the results or doesn't receive the care that the patient is entitled to, then we're going to be in trouble. If the patient can sue us, if the patient becomes, the condition worsen, not good. So we have to have all the information there, up to date. Prescriptions. All right, so how we deal with these prescriptions? Unfortunately, that happens back in the days. We have a prescription pad. It was paper, so we have to sign it. So that's good. See, the prescription pads are printed. They have 2 or 3 copies, but these do not have carbon in between them, this paper. No, they are automatically no carbon required. So this is just a paper that we write on top and it goes on the bottom. And we're gonna have them because we need the original to go to the pharmacy, the copy to put it in the patient record. So that's how it works. Now, every single time that the doctor writes a prescription, the doctor enters this prescription number. They have numbers, chronological numbers. And whether you have to call the pharmacy for the prescription, or if it does one of, the schedule or levels of medication that you can call, or the medical doctor is going to call for. Again, we have to follow this. But one of the most important things here is for patients' privacy, we should not leave these prescription pads on top of the counter, the doctor's desk, not leaving it on top, not leaving it on the counter of the front desk. No way, like the medical records, leaving it somewhere when someone else can put their hands on it, because these prescription pads are, as opposed to the medical records, these prescription pads are stolen. People steal them. Then they filled out with medications, and then they send someone else to the pharmacy to claim them. So that's not good. They forge the doctor's signature. Some of the doctors already have their signature printed on it or stamp it. When I was dealing with this, I never stamped this. I have my prescription pad blank. And I have my stamp with me. And if I have to give a prescription to the patient after I discharge them home, then I stamp it. But that's not what everybody does. They kind of stamp all of them. No, that's a waste of time. I'm not going to be stamping every single time. So they stamp all. Somebody steal it. They just put a signature right there. Who the heck knows what is the signature? They bring it to the pharmacy and I ask for all these medications, whatever they want, particularly these addicted medications. So that's basically what it is. That's something that happens a lot. Oh, well, that's the reason now we have electronic prescription pads. So just for you to know, I don't recall the last time that I saw someone using a prescription pad. So most of the doctors now, they have these electronic prescription, way of giving medications to patients. Releasing medical records information. Now, remember, to release the medical records, we discussed this already. The patient has to authorize first that his or her medical records be released. And to who? And for which reason? Remember, the patient has to fill out a form and sign it in front of us, not over the phone, not sending someone else in charge to do it. That doesn't work. See, patient must sign an authorization for release of medical records. It's the patient itself, no one else. Unless it is minor and it is the custodian, the parent who proves, who shows ID and everything else that this belongs, that this child is his or her daughter's son. Or an elderly person, someone who is not mentally competent. So that's a different issue. But they have to show us papers that they are the custodians. Patients cannot revoke previously signed authorizations for release of records. So let's say that you wrote down that, you fill out you completed one of these forms for the release of information, then you decide to back up. No, now I know it is too late, particularly when the papers have been released already. If you come to us one day after, because remember, it's going to take between 7 to 10 days, working days, that it's going to take for this information to be released, to make the copies, for the doctor to evaluate what is it that needs to be sent, or copy or release, whatever the case may be. So if the information has already been released, there is no question that, how are you going to bring that back? It is impossible. Again, release only records that are specified on the request. If the patient requests for certain things and to who this information is going to go, it's only what the patient requests. But the medical records have a lot of stuff that the patient doesn't know exists. So the medical doctor review the chart, review the information, and the medical doctor is gonna mark each page, each section that you should make copies from. And only those pages are going to be photocopied. Just because the patient asks for the medical records copy does not imply that everything that is contained within the medical records is going to be released. No. What is the patient needs to release these medical records for? Oh, for this particular medical doctor, for this particular procedure, we only going to focus and release and photocopy the information that this other practitioner is going to need. What is the medical order? But it's going to need the correspondence or the notes that I send my patient about not payment or something. Those are necessary. They are not needed. We're going to need something that is based on the medical history, exams, laboratory procedures, results, diagnosis. That's what we're going to send them. Anything else is irrelevant. So that's the reason why the doctor has to review it and tell us what should be photocopied, what should be released. So that's how it works. So here it is this is very simple. Actually, it's more complex than this. Release medical record information. So it says there, from who, to who you're gonna be releasing this. You have to say, it's a medical doctor, what is the practice, what is the address, what is the phone number, what is the email, everything about the doctor if you're planning to give this to a doctor. Remember, the patient has to tell us exactly what is the purpose of this information that I'm gonna release to you. So probably some of you are saying it's none of your business because that information is mine. Well, it is our business in the medical office because the medical records belong to us. Now, somehow I'm protecting you. Remember what I said yesterday? If you come to my office and you request and you sign one of these papers and you tell me or you wrote down in the release of information form that you need these copies for you because you need to have it. And then you sued me, you give it to an attorney so they can sue me, that is invalid. You cannot use it for the purpose because the reason that you want this information was for you, was to give it to another doctor, but you give it to an attorney so they can sue me. No way, it doesn't work that way. That's what these documents are all about. That protects us. It protects the patient just in case someone else uses their information for other purposes. But if you are releasing it, you have to tell me to who you want to release it because otherwise the patient can sue me for releasing the information and not asking the patient. Let's put it this way. The patient calls into the office. You answer the phone, says, oh, listen, my husband is going over there. Can you give them a copy of my medical records, please? Oh, but you have to pay. Each page is going to be costing you $1. No problem. My husband has money. He's going to pay you. Oh, no problem. What time he's going to come? Oh, at this time. And you go and make the copies and give it to this person. Let's put it up. That's everything's wrong because that's not the way information from the patient is released. It doesn't matter who the person is related to the other one. It doesn't matter. It has to be the patient who signed this document. This patient has to tell me all the information about to who this information is going to go. All the information. And I'm going to keep a copy of this because we're going to have a copy of this. And then you're going to use it with a different means, with a different purpose. You cannot do it. You waste your time. So that's the reason why we have to protect ourselves. Remember, we have to collect all the information from you and to who and what is the purpose. It has to be a reason. And the reason is very important because if the reason that you're asking for these medical records have a different purpose, the one that you stated, this is not valid. So again, it sounds like it was easy, right? Oh, the patient signed, said, oh, just give me the medical record. Where did I sign? Not so fast. It doesn't work that way. Let me get some information. Who are you going to be sending this? Oh, doctor. Okay, I need all the information from that doctor. And then we're going to contact the doctor. What specialty this doctor has. And then we're going to send you because we can just deal with the doctor. Okay. So instead of you coming in and picking up the medical records, we're going to send it to them. Okay. Because we have all the information. But if you have other means in mind, hey, you probably wanted to collect it yourself. But it doesn't work that way. So this is 100% question on your exam. Remember, this is violation of confidentiality, releasing the information without the patient's authorization, sign authorization. You have to. So you need the patient to sign this in person, face to face, not by phone, not through email, text message. Good. Okay, so let's go on right here, retention. Okay, so here I have this page from yesterday's class where we're gonna find the schedule for retention of certain documents. So just read it. So it's for you. For how long vaccination should be kept, certain financial documents, and certain information about the patient. So that's basically what it is. So whenever you have the time, just read it, just for you to have an idea that there are certain documents you're supposed to be keeping them for a certain period of time. This is not going to be asked on the exam, but remember, statute of limitations, 7 to 10 years, will. Active, inactive, and closed documents, that's going to be us. New patient, established patient, those things are going to be us. You need to know what is a new patient, what is an established patient. So again, simple things, but if you don't know it, you just can, miss the opportunity, which is not recommended to you at this time. Okay. We are done with this. So this is just a small summary of everything that we covered. It says right there, all duties performed in the practice are learning opportunities. So you're going to be learning every single time through. You're going to be seeing, doing and seeing how the practice functions. You're going to be doing things and then you're going to get your own techniques, how things works easier for you. Were you doing it wrong? Were you spending too much time doing something? Now, because you now learn the proper way to do it, then you're not going to waste too much time doing things. As for additional responsibilities, well, this is not just responsibilities, kind of, you asking for more, right? More work, but less money. No, it's just that in your time off, don't wander around. Find something to do. We don't like people who are just wondering, what is this person not doing anything? Then I'm going to ask you to do something and you're not going to like it. Remember, during the time at work, you need to show that you are busy, that you're always doing something. If you don't, then you're going to be in trouble. In an office, there is always something to do. There is papers to be filed. A lot. We talk about this already. What is the problem with the papers not being filed on time? So do that. Check all the correspondence that comes to the office. Every day the mailman is going to drop information. And if you accumulate yesterday's, today's, and tomorrow's, oh, well, think about it. So just do a little bit every day. Keep yourself busy. If not much to do, well, I have all this correspondence. I'm going to open my envelope. I'm going to take a little time. Actually, I'm going to try to read what it is inside. And it says, oh, this goes for this doctor. Let me put it on this bin. Let me put on this other one. So, this is incoming mail. Oh, this is for the doctor. Usually I put right here, I'm going to bring it to the doctor. The doctor doesn't have patients right now. I'm going to give it personal. Go get it to them. You see, you're doing something. It's not that you're wasting time. It's not that. Remember, in your workplace, people is worried about that you're not doing anything. So always keep yourself busy doing something. Don't do something too fast if you see that you don't have too much things to do. This is not like when you are at home, that you do all these things, oh my God, I need time to go watch the soap opera, to go to the supermarket, so I'm going to rush doing this. No, that's not like that, because you have a schedule. You have time for breaks. So if they see you wandering around and things like that, believe me, or they're going to add some stuff to you and they're going to give you a lot of stuff to do. And you're not going to like it. Or they're just going to get rid of you. Remember what I told you, whenever you are doing something, work as a part of the team. Always be ready to assist a coworker. Oh, you're having problems with that client. That client is kind of very combative, very angry. It's insulting you. You know what? I'm just going to jump in. Not jump on top of the patient. No, you're just going to kind of break the ice. Oh, hi, how you doing? Let me handle this. and you're gonna be allowing someone that can do better. You are more calm, you are nicer, you know how to address the situation, you take the patient to private room, you start talking, solve the problem. Somebody's very busy doing something with the phones, and somebody comes in, jump in, take care of the person while the other person is doing something else. Remember, we have to work as a part of the team. And if you do like that, I'm gonna like you. I want to be working with a coworker that, when I need something, they're there for me. Not only when they need me, I should be with them, but when I need them, they're not offering the resistance. That's not good. Remember, this is a relationship. So I help you, you help me. That's how it works. Any questions about, whatever we covered with these medical records? Because we are going to start tomorrow. So tomorrow morning, I'm going to send you the other chapters for electronic medical records, because I have to still remove some of the stuff that is too complicated. So I'm just going to talk about basics based on what you're going to be doing, based on possible questions that are going to come in the exam. So I usually review all these PowerPoint presentations. Okay, it's a lot of material that I have to do because I have other things to do besides this. Okay, so any questions? We can gonna be done. Anyone? Okay. So we're gonna leave it here. We finished. We're not gonna start another chapter. We have like 10 minutes to 9. So it's been a lot of information, a lot of stuff that we're going through. So again, we're just gonna leave it here. Okay. Thank you so much for attending the class. You guys have a good night. Get some rest. See you tomorrow, same time.
Thank
All
you.
right.
Thank
Okay.
you. Good night.
Thank you. Good night. Good night, everyone. Get some rest. Eat something. I said eat something, not drinking something. All right.